Good everybody, or good afternoon, depending on where you are within the country. My name is Colleen Greco. I'm on the board of directors at the Lewy Body Dementia Association, and am really excited to welcome you to our first webinar. Hopefully first of many, and your feedback is greatly appreciated. So please make sure you touch base with the organization after the session, and let us know what you thought of the series, or I'm sorry, of the session. Today's session is entitled New Insights into Lewy Body Dementias, and we have a sub-guest speaker, Dr. James Galvin, who has a long list of credentials, which I will go through in a second. Very well-respected neurologist and expert in Lewy body dementia. So I'll go through some housekeeping notes to ensure for folks that have not ever attended a WebEx, you're clear on how it works. So as I mentioned, all lines are muted for the duration of the presentation, and if necessary, we can unmute for you to ask your question. Today is recorded for future playback. And to ask a question, if you look at my screenshot here, you should see sort of a blue question mark. That's the Q&A panel. So if you click on that, make sure that you send it to either the host or one of the panelists. And I would like to receive your questions. We'd prefer not to receive it in the chat window if possible. I'd also like to quick remind everybody, October is what we're month to remember. This is our grassroots awareness campaign. It started last year and received lots of positive feedback in terms of what our volunteers and our constituents wanted to see within their communities. We'd like to urge you to get connected, either register in our Hubs of Hope directory, register for our newsletter, which you can do at www.lbda.org, or like us on Facebook. For any questions on how to get connected, I've indicated the email address here, awareness@lbda.org, for more information, where you stay connected. So if you're a member of our Hub of Hope, or receive our newsletter, or Facebook fan, like to make sure that you get involved within your local community by either joining an existing special event or a support group in your area. And of course, I want you to pass it on. We have a large volunteer base, but of course, would like it to grow. This is a disease that affects over 1.3 million Americans, and would like to get the word out and bring LBD out of the shadows. So today, like I said, is our first of hopefully many webinars. We'd like your candid feedback. Our guest speaker today is Dr. James Galvin, Director of the Pearl Barlow Center for Memory Evaluation and Treatment. He's also the Director of the Comprehensive Lewy Body Dementia Center, the Director of Clinical Operations at the Center of Excellence on Brain Aging at Angone Medical Center. Here in the Departments of Neurology and Psychiatry in the New York University Langone School of Medicine. He serves the LBDA Board of Directors and is a member of the LBDA Scientific Advisory Council. So with that, I'd like to turn over to Dr. Galvin for today's presentation.
Well, good evening or afternoon to everybody out there. There are 206 people on the call so far, so this is outstanding. So what I'd like to do over the next 20 to 30 minutes or so is give you an overview of some of the newer discoveries into Lewy body dementias. Now, I'll have to admit I'm going to focus a lot on some of the things that I've been doing. There are many other researchers across the world who are doing research, but I thought since I'm going to be doing the talking, it would be easier to talk about some of the projects that I've been working on and how they may be relevant to helping us understand more about the disease. As soon as I figure out how to forward the slide, we'll be doing great. Can I have slides from me? You can,
just to the left of the participant icon, there's an arrow. Or for you.
Okay, drive. Next slide.
I did. We're on the objective slide.
Okay. Doesn't say anything. I don't have a new slide on mine. I have the same thing. So I'll just talk from my other slide deck. we're going to talk a little about the objectives, so let me review some of these for you. So first, we're going to look at some of the clinical and cognitive and behavioral features of the disease. That just to understand, when we talk about Lewy body dementias, everybody's starting from the same point. Then what we're going to do is talk about how we might be able to distinguish Lewy body dementia from the common form of dementia, which is Alzheimer's disease. And this is really the diagnostic challenge that many physicians face when they're seeing patients is, does the person have Alzheimer's disease or do they have something else? So we'll focus on that first. I see a couple of questions. There's the slides aren't moving, so there's just the initial title slide, Colleen. And I see people writing that in as well.
Okay.
That is great, isn't it? Really a fascinating thing. I can do shadow puppets if you'd like. I'm not afraid that I can do
usually works.
I can do a dog, but that's about it. Talk while we're trying to find all the slides because we haven't really done anything yet. So I talked about we're going to review the symptoms. I think that's important. Second thing we're going to do is to help distinguish between Lewy body disease and Alzheimer's disease. So those are two key points that we're going to focus on. The next thing we're going to do is talking about what some of the research there is that we be able to improve our understanding of the diagnosis and understand some of the outcomes of Lewy body dementia. Then we're going to talk about, just very briefly, about what some of the current treatment options. And I can tell you up front, there are no approved medicines for Lewy body dementia, but we can be very effective at treating some of the symptoms. And then we're going to go and look at some of the challenges that everyone faces when they're dealing with patients with Lewy body disease, whether it's the caregiver or the physician. So we're going to talk about all of these things. Lots of funny things happening on the screen right now. Let's see. So see an objective slide, but I don't see me anymore.
Just continue. If you can see objectives, I can drive from here.
Okay. So I'm through the objectives. Let's go to the next slide. All right. So I think we're on track now. So let's talk about what Lewy body dementia is. So in 1995, a group of investigators from all over the world got together in England, and they had a consensus conference and came up with the criteria for dementia with Lewy bodies. And so this was first published in 1996, and then there were two other conferences. So the latest criteria were published in 2005, so that's what this slide talks about. And so in order to make a clinical diagnosis of Lewy body dementia, you need to have several features. So first, there has to be a dementia. Dementia means that there's some progressive change in cognitive abilities that represents a change from someone's previous level of abilities and interferes in some way with their social or occupational functioning. So it changes the way they do things. And there are core features. And so for Lewy body dementia, you need at least two of these core features for a probable diagnosis. So the first is fluctuating cognition. And we're going to talk about each of these individual symptoms in a little bit. But this variation in the level of attention and alertness that the patient may experience can have visual hallucinations, or they can have signs of Parkinsonism, that is, the features of Parkinson's disease. And we'll talk about each of these separately. There are also some suggestive features. These are suggestive because they're very associated with the disease, not sufficient enough to make a diagnosis. The one we're going to focus on mostly today is one called a REM sleep behavior disorder. REM stands for rapid eye movement sleep. Again, we're going to go through each of these features individually. Patients also have a sensitivity to neuroleptic medication. These are medications that are used to treat some of the behavioral phenomenon, and particularly some of the older ones can have some very adverse consequences if they're used inappropriately. Imaging, they can have some abnormalities in a study that looks at dopamine uptake in the brain, and I'll show you a picture of that later on. And there are some supportive features. So we can't use these to help us make the diagnosis, but present in enough individuals that it's useful to consider when you get a person with some of these features, do they have Lewy body disease? And this includes repeated falls, loss of consciousness, Autonomic dysfunction. By that we mean changes in their blood pressure and heart rate regulation. Particularly when they stand up, they might feel lightheaded or dizzy. They can have systematized delusions. A delusion is a fixed false belief. They can have hallucinations in other modalities. So besides visual hallucinations, they can hear things, they can smell things, they can taste things, they can feel things, although all of these are less common. And they get depression, which is very common in all of the different dementias. Next slide, please. And is that when we talk about Lewy body dementia, we're including really two that were originally thought to be separate diseases. The first is dementia with Lewy bodies, and the second is the dementia associated with Parkinson's disease. So individually, there have been criteria developed for each of them. And talk about how we're going to group these together in a second. If someone has Parkinson's disease and later develops a dementia, we have criteria to help us decide this, and this was published about 4 years ago. And so first, you have to have a diagnosis of Parkinson's disease, and the movement component has to begin prior to the onset of any cognitive problems by at least a year. When you see them, they have to have some problems. So the MSE stands for Mini Mental State Exam. So some type of pencil and paper test. They're scoring below what the cutoff for normal appears to be. They can have cognitive deficits, again, that interfere with their everyday activities, because that's the definition of a dementia. And they have to have problems. So they can't do memory tasks or concentration tasks or drawing tasks. So a whole bunch of different types of areas we can look at for cognition. We're going to focus on that a little bit in the later slides. And again, they can have other features. So they can have problems with sleep. They can have problems with mood. They can have delusions. So we have features for Parkinson's dementia. We have features for dementia with Lewy bodies. What's interesting is that they may be the same disease that are just separated by which symptom comes first. So sort of a chicken and an egg kind of question. Next slide, please. So rather than thinking about, just the single entity of Lewy body dementia, it really probably represents an entire spectrum. And I don't know if I have control of a mouse here, but I don't. Thinking about just a disease, if we think about it as sort of a spectrum, so there's a pathology, a spectrum of pathology, that's Lewy bodies, and I'll show you a Lewy body in the next slide or so. And there's many patients also have some Alzheimer's disease changes. And so depending on the extent and the type of pathology that's present, you can have lots of different symptoms. So if you just have pathology in one part of the brain, you might just have motor symptoms. If you have just pathology in another part of the brain, you might just have cognitive symptoms. If you have pathologies in both parts, you might have both motor and cognitive symptoms. So that you can have cognitive symptoms, they can have memory problems, they have difficulty solving problems, they can have trouble with their visual skills, they can have trouble with attention. They can have mood changes, so they can have depression, anxiety, apathy, a loss of interest. They can have behavioral phenomenon, hallucinations, delusions, agitation, aggression. So again, it really depends on where the pathology is located. Next slide, please. With that in mind, how kind of a problem is this? What's the frequency of this? Well, when we look at all the different studies done by many investigators across the world, and we look at cases who come to autopsy, we Lewy body dementias cause about 10 to 15% of all dementias. We also know that people who are diagnosed with Alzheimer's disease, about 25% of them develop other signs later in the disease, such as Parkinson's, and many of those people will have Lewy bodies in their brain. We know that Parkinson's disease, that begins just as the motor disorder, has a possibility of having a dementia which increases about 14% per year over the age of 70. So if you look at all these individuals, they all have Lewy body dementia. So a combined sum of people who have both Parkinsonism and dementia, as well as these behavioral features we're going to talk about, approaches 1.3 million Americans. So very common disorder. Alzheimer's affects about 5 million. We have Lewy body affecting about 1.3 million. So you can see it's about 15 to 20% of all the cases. That's a substantial number of cases. That's more cases than there are of HIV in the United States. That's more cases than there are of multiple sclerosis in the United States. It's a very common disease, but it's not so commonly recognized by many of the clinicians that you take your loved ones to. Let's go to the next slide. So what exactly is a Lewy body? Well, a Lewy body is an abnormal collection of protein in the brain. So the left-hand side of the slide, we have what's an old classic stain. It's called a hematoxylin and eosin, or H&E. Don't worry about it, what it is, but basically we use colored dyes, and the dyes bind to the different structures of the brain differently. And so you have to look very hard to see this. So what little arrow is on the slide, that's a Lewy body. It's very hard to see. It doesn't really stand out from the background. And we think that that's why it took such a long time to really understand a lot about this disease. Advent of modern techniques, we have identified the protein that is the building block of Lewy bodies. It's a protein called alpha-synuclein. Now, we know exactly what alpha-synuclein does. We do know that when it becomes abnormally clumped together, it forms a Lewy body and causes disease. The panels that are on the right-hand side of the slide are using antibodies against those proteins. You see how much easier it is to see that abnormality, that brown ring. That represents a Lewy body inside the cell. So you can imagine that, in the 1960s and 70s and 80s, before we knew anything about the protein, there were a lot of people that had Lewy body disease, but we couldn't recognize it because it was very hard to find them under the classic stains. With the modern techniques, we're able to identify many people that have Lewy body disease. And in this, we hope that we'll be able to develop some biological markers of disease that will help us improve the diagnosis. I'm going to focus on that in a little bit. Let's go to the next slide. So what we'll do now is we're going to review the core clinical features. So I talked about the criteria before. Now let's go through each of those symptoms so that we can better understand what are some of the symptoms. So first, what are some of the cognitive signs? Patients with Lewy body dementia have significant difficulties in their visual system. So they have trouble following things as they move. They have trouble with visual attention. And so many people think, well, I need new glasses. So they go to the eye doctor, and the eye doctor changes their glasses, but things don't get better. It's not really their eyes that's the problem. It's their brain interpreting their eyes are seeing and being able to understand the information. Trouble initiating actions, either verbal initiation or motor initiation. So they're very slow into response, both when they're giving an answer as well as when they're moving. And they can impair their ability to do a lot of tests. They have trouble doing what we call construction. So if we give them a blank piece of paper and we have to draw a clock, it's difficult for the person with Lewy body dementia to plan out what that clock would look like. And we time them. So we give them something to do, and they give them a set amount of time to do it. Because they move slower, they have a lot of trouble doing these tasks. Next slide. What are the motor signs, sometimes also called extrapyramidal? Okay. They be rigid or stiff. They tend to have unstable balance, so they tend to fall a lot. They walk, they tend to shuffle. The medical word for shuffling is festinating, but shuffling works just as well, and so they tend to shuffle their feet across the floor. They may not have a tremor associated with this. If they started off with Parkinson's disease, they will more frequently have a tremor. If the motor symptoms come later in the course, they often don't have a tremor. And this really becomes tricky for a lot of clinicians because people expect Parkinson's symptoms to have a tremor. In Lewy body dementias, in many cases, there is no tremor, so that makes it very difficult to tease out. And also have an irregular jerk-like movement, so they could be sitting in the chair and you can see just a sudden jerk. I don't know if you could see that on the camera or not. That's called myoclonus. It's an irregular jerk-like movement. It may occur just as they're falling asleep, but it may occur at any time during the day as well. And you can see all of these different motor symptoms as part of Lewy body dementia. Next slide. So what are these cognitive fluctuations? Well, you fully understand what they are, and in fact is I don't know if anybody really fully understands what they are. It's by far the most confusing aspect of the disease. And if you get 100 experts in a room and ask them to define what cognitive fluctuations are, you could very well get 100 different definitions. So you can just imagine how difficult this is. But most of us agree that it is spontaneous impairment in someone's ability to pay attention, to concentrate, to be alert. So the patients are looking ahead, but they may seem drowsy, kind of daze or stare. And these staring spells, they can last from minute to minute, from day to day, from week to week. So you may not see any of these for a long period of time, and they may go through a whole week where every day you see these episodes. At the extreme, there's actually been a loss of consciousness associated with this, but this is not a seizure. It's not a stroke. We don't know what's causing it, but it seems to be some dysregulation in the way the brain cells are talking to each other. And so a person, even though they're awake, their brain is acting as if it's asleep. The scale that was developed by an investigator in Florida, Dr. Tanis Furman, I find very, very helpful. It's called the Mayo Clinic Fluctuation Scale. And so we ask 4 questions to the caregivers. So does the patient seem drowsy or lethargic during the day despite sleeping the night before? Do they sleep for 2 or more hours during the day? Is the train of thought, their thinking, sometimes illogical, unclear, or incoherent? And do they enter into space? And that you can answer 3 or more of those questions as yes, then it would suggest there's a fluctuation. Next slide. Behavioral disturbances. Well, common behavioral disturbance is a visual hallucination. Now, this may be more common in patients who already have poor eyesight. Seeing things, and they're not really sure what they're seeing, and you don't know whether it's due to a cataract or glaucoma. They tend to be well-formed hallucinations, most typically of little people or furry animals. They may or may not be frightening. There may or may not be any auditory component to this. So there may be little people, and the person may talk to the little people, but the little people don't often talk back, and that can be frustrating. And they occur early in the disease. And this is quite different than Alzheimer's disease, where hallucinations, if they do occur, tend to occur late in the disease and tend not to be well-formed. They be kind of shadowy figures off in the background, but they're not well-formed figures. So if you're someone who's having a well-formed figure, that would suggest Lewy body dementia. There's also delusions. Delusion is a false belief. So the most common is a misidentification delusion. That is, you look at something that's actually there, but you think it's something else. So you look at the chair and you think it's a person, and I can't convince you that the chair is not a person. That would be a delusion. There's called capgras, which is where the spouse or caregiver is replaced by an identical imposter. So you're someone who looks just like you. Know that you're not you. And I'm looking for you because I don't know where you are. And that can be very disturbing. There are other delusions. One's called a phantom boarder. That's when you believe that someone else is living in the house with you. It's like the capgras, only it's not necessarily the caregiver. It might just be a mysterious figure. There was a famous book written by Joseph Conrad, The Secret Sharer. I don't know if anybody ever read that, but that would be an example of a phantom boarder delusion. And they'd be paranoid, so be very suspicious. Next slide. They can have depression. They can have anxiety. They can be very irritable. They can have lack of motivation, a loss of interest. That's called apathy. Occasionally can be aggressive or violent, particularly acting out against some of the delusions or hallucinations. And like many patients with cognitive problems, they get a little bit more confused at night. So as some of the signals decrease because the ambient light is becoming less, people can become more confused, and those shadows can be misperceived as something else. Next slide. Sleep disturbance, this REM behavior disorder. So REM stands for rapid eye movement, so that's your dream sleep. And normally when you're dreaming, the only thing that can move are your eyes. The rest of your body is essentially paralyzed. In this disorder, people tend to out their dreams. So they tend to be dramatic or violent dreams. They can kick, shout, thrash, punch, grunt, all sorts of movements and noises. The patients tend not to be aware of this because they are in fact asleep. Often it's the bed partner is aware of it because they're the ones that are either being woken up by the shouting or kicking or punching. It's common in men, and they begin actually years before any of the motor or cognitive signs. So maybe a decade or 2 before any evidence of Parkinson features or the kind of changes, the dementia. Next slide. One interesting thing is that we've looked at a number of ways of looking at this, and so we looked at cases who had come to autopsy, so we knew what they had. These are people we had followed for a long time, and after they passed on, they donated their brain, so to study their brain. So exactly what was wrong with them. And we compared the groups. We found that Parkinson's disease dementia and dementia with Lewy bodies are the same disease. Basically, almost all of the features are the same, except that the motor symptoms are a little bit worse in the Parkinson's disease patients. So that's why we can generally group Lewy body dementia as being both Parkinson's disease dementia and dementia with Lewy bodies, put them under the same umbrella. Compare them to Alzheimer's disease, we find that Parkinson's disease dementia is different than Alzheimer's disease. Dementia with Lewy bodies is different than Alzheimer's disease, and they're different in the same exact way. So Lewy body diseases are very common amongst themselves, and they are distinct from Alzheimer's disease. So you look for these clinical features that we've been talking about, it does make it much easier to make a diagnosis that's accurate. Look at the next slide. So those features that we can look at. Well, in our study, we looked at people who came to autopsy and looked at what some of the clinical symptoms are. Well, Lewy dementia is more common in men, so being a male puts one at increased risk, although you can't change that. So, and not every male will develop Lewy body dementia, and some males develop Alzheimer's disease. So by itself, that's not helpful. But if they have any sort of movement problem, they're likely to have a Lewy body disease. If they have cognitive fluctuations, if they have any type of hallucination, if they're very sensitive to medications that are similar to those neuroleptics. So some of the anti-nausea and anti-vomiting medicines chemically are identical to neuroleptics. And so people have adverse reactions to those medications. That may be an early sign of a Lewy body disease. This regular jerk-like movement, myoclonus, is a predictor. If people have depression in older life, that is a predictor. Any of these sleep disturbances that we talked about that may begin decades before, that is also a predictor. So with all that information, it makes it much easier for us to begin to develop models through research to understand more about the disease. So let's go next slide. So this little part right here. So first, the phenotype, that is the clinical symptoms of Lewy body dementia, includes being male, having hallucinations, being sensitive to drugs, having depression, fluctuations, sleep disturbances, and these irregular jerk-like movements. The presence of any of these is very predictive. And so if you're seeing an individual, that really does help you. There's no difference between Parkinson's disease dementia and dementia with Lewy bodies, which is why for the rest of the talk we're going to group them together when we're having the conversation, other than what came first, the chicken or the egg. Next slide. Talk about some research. So I'm just going to show you some pieces of research. I'm not going to go into a great detail. I just want to give you a flavor of what's going on. So one of the things we've done is we've used some very, very fancy statistical methods. So don't worry about the statistical method, but it allows us to look at individual cognitive domains. So not just looking at memory overall, but breaking it down into all its different parts. So with red line, we're looking at working memory. That's the ability to do full concentration. So if I give you a task, you have to hold the task in your head and manipulate it without using a pencil or paper. Visual spatial skills are things that require a hand-eye coordination component to them. Verbal skills are things that I ask you to do out loud. So I ask you to remember a list of words and repeat it back to me, or ask you to name animals. And verbal means that if I take all those and look at them together. And what I want you to take away from this is if you look at how the lines are declining over time, you see the line that has the steepest decline is those visual spatial skills. Those are the things that appear to change the earliest and are the most severely impaired in the Lewy body dementias. And that may help us begin to tease out the difference between Alzheimer's disease and Lewy body disease. Next slide. So in these type of studies was that Lewy body dementia is characterized by these visual spatial, these hand-eye coordination, depth perception kind of problems. They begin up to 3 years before people are diagnosed. And the classic memory test may miss the early stages of Lewy body dementia because those classic memory tests aren't affected in the early stages of the disease. Disease that has no Alzheimer's disease at all is very rare, but may have more severe visual spatial problems. But people who have both Alzheimer's changes and Lewy body changes tend to progress at a more rapid rate. So 2 diseases is worse than 1 disease. So we've learned some very useful information in that fashion. Go to the next slide. So I'm going to talk about something else. So one of the things we're interested in is, are there some personality traits that help us distinguish between the disease? Next slide. And what we found out is that when we compared people with dementia versus no dementia, they were more irritable and cranky and a little more rigid in their thought. That's probably true for everybody that has a dementia. when we looked at trying to separate Lewy body dementia from Alzheimer's disease, we found some interesting patterns. And in fact, patients with Lewy body disease tend to become more withdrawn. They tend to relinquish their hobbies, show less interest in the world around them, become quieter in social situations. And that's different than we typically see in the pattern of Alzheimer's disease. So while we don't measure personality traits, typically, if we thought about those things, it might help us improve our ability to detect disease. Next slide. And so this slide just summarizes what I just said, that we can use these things to help us. Because there are no batteries specifically done by physicians to diagnose Lewy body dementia, but if we ask the simple question, has his personality changed? And if you told me, yeah, they're becoming quieter and more passive and more withdrawn, that might lead me to suspect Lewy body disease. Next slide. What about biomarkers? You probably heard this term biomarker. Next slide. What exactly is a biomarker? Well, a biomarker is simply a measurement. It's some marker of disease, and can tell us whether someone has the disease. We can predict it. Whether it's present right at the present times for diagnosis, or whether we can watch its progression, so monitoring. And we can get this from different type of imaging studies, from spinal fluid, potentially from blood, although not yet, but potentially from blood, or we can get genetics. Let me give you some examples of some of the work that we're doing. Next slide. So people are mostly familiar with an MRI. I mean, these are commonly done clinical tests. I think they'll pop up any second now. And so MRIs are clinical tests, but if you do specialized research MRIs, you can use computer programs to actually tease out, like draw little sections and pull them out, and the computer can make a three-dimensional map. So in this particular slide, I'm showing you how we take a piece of the hippocampus, which is one of the memory centers of the brain, and we can pull it out and create a three-dimensional map. Next slide. With the shape of things, we can begin to understand a lot more. So the pattern that's up right now, Alzheimer's disease has a certain pattern for how the hippocampus changes. Can you click again? If someone has pure Lewy body disease, you can fully appreciate it, but the pattern of how the hippocampus is changing is very different than the pattern we see in Alzheimer's disease. And if you one more time, and it's a mixed picture, so both Alzheimer's disease and Lewy body disease, the pattern that's intermediate. So if you look at the pattern that's closest to the head of the campus, you see that's in Alzheimer's disease, but not so much affected in Lewy body disease, but you see that in mixed Alzheimer's disease, Lewy body disease. So these patterns allow us to begin to tease this out. Now, this is not a clinical tool. You can't go to your doctor and order this test. I just want to give you a sense of what we're trying to do from a research program to improve our ability to diagnose. And hopefully someday we'll be able to do these as clinical tests. Next slide. A research tool that we use is something called functional MRI. So functional MRI, instead of looking at the structure of the brain, we look at how the brain functions, how it's connected. So what we can do is we can plant a seed in an area of the brain, and then we look and see where that seed is connected to other brain regions. Okay? It's really complicated. Don't worry about the complexity of it so much, but just suffice it to say that dementia with Lewy body is different than controls without dementia, and the brain is different than Alzheimer's disease. So we can use these functional MRIs to help us discriminate between individuals with disease. And very powerful. If you combine both the structural imaging that I just showed you plus this functional imaging, it could be a very powerful tool eventually someday that would have us almost absolutely able to discriminate between the different causes of memory problems. Next slide. What we can do is something called a PET scan. So a PET scan is a radioactive study. We give a small injection of a tracer, and it binds to something. And so in this case, we're bound to the amyloid protein, present in Alzheimer's disease, but is present in about 80% of patients with Lewy body disease. What's interesting is that if someone presents with a motor presentation, they tend to have less amyloid. And someone presents with a cognitive presentation, tend to have more amyloid. So amyloid by itself doesn't really help us all that much. Next slide. The dopamine system. So dopamine is a chemical that's important for movement. So in a PET scan, we can image this, and you can see in the far left panel, there's a picture of a healthy control brain. And so dopamine uptake in those regions is very, very bright, that's why it's red. In Parkinson's disease, you see there's less uptake. In Alzheimer's disease, it looks just like the healthy controls because they don't have a problem with their dopamine systems. And in dementia with Lewy bodies, it looks like Parkinson's disease. So imaging dopamine systems may be another way that we can begin to tease out between the different disorders. Now, this particular compound is not available clinically yet, but we think it will become available clinically sometime in the next few years. Next slide. I mentioned that protein synuclein before, the building block of Alzheimer's disease. Well, we measure it in the spinal fluid. A spinal is not the easiest thing to get. It requires a lumbar puncture or a spinal tap. The ideal would be to measure it in blood, but it's not a very accurate measurement in blood at this time. But we measure it in spinal fluid. But what I want to just show you with this another complex slide, I like pictures because I don't have to point to the picture, but you can kind of look at it as I'm talking. The spinal fluid synuclein actually changes depending on what the person's underlying condition is and their age. So that's important. So in body cases, it declines with age, but in controls, it increases with age. So understanding the way the protein is changing and the age of the patient would be very important to be able to interpret what this actually means. Next slide. So the take-home message of what I'm trying to say about these biological markers is that because Alzheimer's disease occurs commonly with Lewy body disease, and because Lewy body disease occurs commonly with Alzheimer's disease, if you just measure an Alzheimer marker, just measure the Lewy body marker, you'll be able to get the answer. What I'm trying to display here is that you may need to do both markers and really understand. And when you use both a Lewy body marker and an Alzheimer marker, you get very nice separation of the groups. And this may someday be the way we're doing diagnoses. Next slide. Just to summarize this part, using biomarkers may assist us in discriminating the diseases. Because they occur commonly together, we may have to do more than one biomarker. So structural with a functional MRI, combine two different types of PET scans, combine two different markers in the spinal fluid. But that's probably what we're going to have to do to really understand the disease to the best of our ability. The next slide. My light, yeah, there we go. What about the current treatment options? Well, next slide. There are no approved medications for Lewy body disease. So we currently treat each of the symptoms separately using medications that are approved for other diseases. So we have medicines that we use from the Alzheimer's world to treat cognitive problems. We have medicines that are used in the Parkinson's world to treat the motor symptoms. Medicines that are in the psychiatry world to treat the mood symptoms. We have medicines from the psychiatry world that's used to treat the behavioral symptoms. And for sleep symptoms, there are different options depending on which type of disturbance there is. So there are treatments for every symptom, but they're specifically indicated for Lewy body dementia. So it's critical to, one, know what you're treating, and two, figure out what's the best choice. And so you should talk with your physician about these things. Next slide. Tie this up a little bit. Many of you on the line may be caregivers. What do we know about what happens in Lewy body disease and the caregiver? Well, the fact is, to date, we have known very little about what challenges are specific for Lewy body caregivers or how best to provide the resources that they need. We also didn't know a whole lot about what the experience of the patient and the caregiver is trying to get a diagnosis. So a couple of years ago, the Lewy body Dementia Association conducted a survey. We had 962 caregivers respond. Maybe some of you in the audience responded. And so it was helpful. We learned a lot. Let me show you what we learned. Next slide. Found that it takes a long time to get a diagnosis, so that the majority of patients saw more than 3 doctors, more than 7 office visits, and it took more than 18 months to actually get a diagnosis. And a different diagnosis was given 3 out of every 4 cases. 3-4 cases, a patient was given a different diagnosis, and it wasn't until this 18-month period that they got a correct diagnosis. Caregivers often feel isolated because they're dealing with the cognitive problems, the motor problems, the sleep problems, the behavioral problems. They don't believe getting the adequate support from their family or friends or from their healthcare providers. About 2 every 3 caregivers had to respond to some crisis by calling the police or an ambulance or taking people to the emergency room. The caregivers really do need more sources of information and support. And more importantly, physicians caring for older adults really need to have greater awareness of how common Lewy body disease is and what different presentations so they can make a timely diagnosis and help the family. Let's go to the final slide. So as I end this section of the talk, and I'm going to open up for questions now, Lewy disease is common, 1.3 million Americans, second only to Alzheimer's disease as a cause of dementia in the United States. It often has a visual, spatial, or attention problem. It may progress more rapidly than Alzheimer's disease. The clinical presentation can vary, but one of the things I talked about is these passive personality traits, which we typically don't ask for, these sleep disturbances, which may not be asked about, and visual hallucinations are very helpful clinical signs of the disease. It's despite all the research I showed you that there's not going to be any one single test that's going to definitively say someone has Lewy body disease. We're probably going to have to do a couple of tests, at least one that looks for signs of Alzheimer's and one that looks for signs of Lewy body disease to really understand what's going on. Lewy body patients do respond to medications. They can be very robust responders to medications, and so the physician shouldn't be afraid to try the medications in the individual symptoms of disease. And Lewy body disease caregivers face huge challenges, and much more support is needed. And one of the goals of the Lewy Body Dementia Association is to provide that caregiver support that's so desperately needed. I thank you for your attention on this part of the session, and I'd like to open it up for questions and comments while I take a drink here. Remember, October is a month to remember. It's Lewy Body Awareness Month.
Dr. Galvin, it is indeed Awareness Month, so welcome to Awareness Month, everybody. Thank you so much for your time. We will get to questions in just a minute, but I wanted to reshare this slide because we had some technical difficulties in the beginning. Three things we asked today. Feel free to choose one of the three to get connected. If you can register in our Hubs of Hope directory so we can help you to connect to your local community so you don't have those feelings of isolation that Dr. Galvin talked about. We'd love to have you do that. Make sure you go on our website, www.lbda.org, and register for our newsletter. There's a lot of valuable information in there, stories, all kinds of resources for you to use. And we continue to provide updates and information on Facebook as well, so if you could visit our Facebook page and like us, we'd appreciate it. Also stay connected. As it is Awareness Month, we have a number of special events and support groups in your area. This is a way to, again, absolve those feelings of isolation and pass it on. The more people that know about this disease, obviously, the better. Diseases like this don't often come with loads of research dollars in the beginning, so the more people that know, the more dollars that will come to us so that we can help the families out there in their struggles. So go ahead and go to the Q&A panel. Dr. Galvin, if you see any that you'd like to address, I'm just scrolling through them now.
There are questions. I'm going to try to address as many as I can. I apologize if I don't get to all of them. So Lisa asks, with regards to REM, if someone shouts out during sleep now, is that a good indication they will develop Lewy body disease or some other form of Parkinson's disease? Well, as I mentioned, the REM sleep disorder is a risk factor. First, the most important thing is determine that that's actually the case. The only way to definitively know this is to have a sleep study, or the medical word for sleep study is a polysomnogram. This is an overnight study where they examine your sleep. So if you are concerned about someone who's experiencing this, you should talk with your family doctor, talk about the symptoms, and see if a sleep study is right for you, and then those symptoms can be treated. Tracy writes, I read rivastigmine and galantamine may be recommended as means to help with these problems or to slow or prevent the decline of cognitive function. Is this true? Well, those medicines, so rivastigmine, galantamine, and donepezil, are all cousins. They're all cholinesterase inhibitors, and they're approved to treat mild to moderate Alzheimer's disease and mild to moderate dementia associated with Parkinson's disease. I mentioned Parkinson's disease, dementia, and dementia with Lewy bodies are really the same thing. So, in fact, we do use those medications, although it's on an off-label indication. And they can be very effective at slowing down the progression of symptoms. So they don't treat the underlying disease. They don't stop the disease. The disease still progresses. They just alleviate some of the symptom burden. So they can be quite effective, and taken as prescribed, they're usually well tolerated. Let's see. Mary asks, please say more about loss of consciousness. My dad has had this a couple of times, come out of it in about 20 minutes. What do, if anything? Great question. Now, never seen your dad. I can't give you specifics. Okay? But in general, as I mentioned, it could be a fluctuation, and where people can be very out of it, very difficult to arouse, and then they'll suddenly perk back up and everything will be fine. However, if not been previously evaluated, I think it's important to discuss these episodes with your doctor. And if the episode lasts for a long period of time, to consider whether emergency services are necessary, because while many cases could be a cognitive fluctuation, the other things that can do this are problems with the heart rhythm, or an arrhythmia that prevents blood from going to the brain. Strokes can do this. Seizures can do this. Medications can do this. So I wouldn't want to attribute it specifically to cognitive fluctuations. So it sounds suspicious for this. Again, in the absence of other evidence, I can't give you a definitive answer. But if you are experiencing this with your dad, you should talk with his doctor about it. So my dad has had a CT, an MRI, and an fMRI, but not a spinal tap. But a definitive diagnosis has not yet been made. In fact, neurologists insist that he does not yet meet criteria for dementia. And I can't give you specifics. The neuroimaging, the clinical neuroimaging that's currently available is going to simply give you a picture of if there's anything obviously wrong. These techniques that I showed you here are all research at this point. But if you look at the criteria that are currently available, right, so changes in cognition, particularly with attention visual skills, cognitive fluctuations, visual hallucinations, REM behavior disorder, mild Parkinsonism, if you have those features, if your dad has those features or anybody else has a feature, that would suggest Lewy dementia. So, having a continuing conversation with your doctor always makes sense. While I don't recommend doctor shopping, getting a second opinion is not unreasonable if you are convinced that something's wrong but you're not getting the help that you need. Ted asks, what medicine best helps Lewy body dementia with orthostasis? Well, I'm not going to make any specific recommendations because, again, in the absence of seeing a patient, I just can't do that. However, there are medicines that are available, but I think the first thing to do is to try a non-pharmacological approach. So techniques for getting her out of a chair, so let the legs dangle for a while before standing up. We can use support hose that sometimes can eliminate the need, keeping people well hydrated, etc. But there are medicines available, 2 different types of medicines that are available to treat the orthostatic hypotension. And so you should discuss these with your doctor and see if your loved one is appropriate for these medicines, because all medicines do have side effects, and you have to look at the whole picture in order to make a medical recommendation. Ask a question, what is the typical lifespan after Lewy body dementia diagnosis? And are studies showing a genetic or hereditary component? So I think typical lifespans is always hard because the way we do it is we look at hundreds upon hundreds of individuals and we collect a median. That's where the 50th percentile dies, survives, depending on how the study is designed. So I don't like giving numbers like that because without seeing people, it's hard to give a context. But in general, for Alzheimer's disease, it's probably estimated to be between 8 and 12 years, and for Lewy body dementia, between 7 and 10.5 years. So it's a little bit faster than Alzheimer's disease, but that's modified by how healthy someone is, how many medicines they're taking, what kind of support structures they have. So, there's a lot of factors that come into play there. All of the dementias in general are not genetic. They're not hereditary. They're sporadic. They occur randomly in the population. It is important that you should always look over the family history, because if there is some pattern where each generation has a disease, you might talk to your doctor further about that. But by and large, almost all of these cases are sporadic, with age being the greatest risk factor. Let's see. Lindsay asks, what actually causes death? Is it complications from disease? Oops. let's see, I was reading the question that went away. Is it complications with disease, or does the disease actually shut everything down? The answer is yes. So it can be many things. So for most patients are older adults, and older adults die of the reasons that older adults die of. And the first three are cardiovascular disease, cancer, and stroke. So those are the three big killers of older adults. The next three killers of older adults are pulmonary disease, infections, and dementia. Severe stages of dementia, eventually the brain shuts down and it just doesn't work anymore. But people who have dementia are at risk for all of those other diseases I mentioned because they're less well able to take care of themselves. Let's see. Janine asked, Lewy bodies seems like a very costly disease. Do insurance companies plan to give additional coverage so patients can get assistance to pay for more physical or occupational therapy? Well, all dishes are costly diseases. The Alzheimer's Association estimates that the cost of Alzheimer's disease alone is $172 billion with a B, dollars per year. So that's the third most expensive disease after cancer and heart disease. Lewy body dementia occurs less frequently than Alzheimer's disease, so you could probably do the math and get some idea of what the cost of Lewy body disease is. Insurance companies don't have any plans to pay for anything that they don't have to pay for. And this is not a diatribe against insurance companies, but the key is something indicated. So if physical or occupational therapy is indicated and there's a goal to be met, then insurance companies will pay for it. So you should work with your doctors to make sure that if your loved one has a need that can be met by therapists, that he or she receives the care that they truly need, and if indicated, insurance does pay for it. Let's see. Some years ago, my mom had a recurring delusion that was kind of like capgras. She believed that she was in a hospital that they had carefully constructed to look just like her home. I heard of this version. I know someone else's fathers. So this is called duplicative paramnesia, which is basically capgras for an object instead of for a person. And so that the place you are is replaced by an identical place, but it's not that place. Typically, it looks your home, but it's not your home. This is a little bit more complex in terms of creating a hospital room, but it's the same type of delusion. Delusions are difficult to treat, but they can be responsive to medication, so it's always good to talk to your doctor about what options may be right for your loved one. Asked, does carbidopa-levodopa stop working to minimize the most symptoms late in the course of Lewy body dementia? So carbidopa-levodopa is a medicine from the Parkinson field that we use to treat the motor symptoms. Unfortunately, as the disease progresses, there's less targets for the medicines to work on, and so typically the medicines become less responsive as you get later in the disease. And so it's a frequent occurrence that what worked well in the beginning stages tends to work less well at the later stages. Sometimes dose adjustment can help with that. Sometimes adding additional medicines can help with that. But sometimes there's really not a lot we can do at the present time to stop what is going on. My mom recently developed issues with her blood pressure, strong variations in it. Could this be an evolution of her Lewy body dementia or a side effect of one of her medications? Well, you should always look for a logical cause. So medicines have lots of side effects, and if someone is having a new symptom, you should always go back and look at are medicines, are there any new medical conditions, or is there anything new lifestyle thing in their life going on? So you should always look for that. But variations in blood pressure is called orthostatic hypotension. That's the fancy medical word for that. Basically means the blood pressure fluctuates when people stand up. Is a common symptom in Lewy body dementia because bodies are present not just in the brain, they're present also in the heart, in the nerves, in the walls of the gut, and in the walls of the bladder. So patients can have other symptoms besides brain symptoms. They can have changes in their blood pressure. They can have trouble sweating when they get hot. They have constipation. Actually, a very common symptom is constipation. They can have trouble pushing urine out of their bladder. So all of these can be related to Lewy body disease, but you always look for other medical cause first. Let's see.
Jim, can I interrupt for one second?
Sure.
This is Angela Taylor, everybody. I'm a Director of Programs with LBDA. It seems we've lost Colleen Greco, who was hosting the meeting, so I just wanted to make sure that I was off of mute and that we would be able to move forward in her absence. So go ahead, Jim. Thank you very much.
Okay. Paul, are you working on an appropriate assessment test for Lewy body dementia? My will scream if she has asked to draw another clock. It's a question, Paula. Many investigators across the world are working on assessment batteries that will help us make the diagnosis at the earliest possible stage. Your mom doesn't like clocks. Unfortunately, clocks are pretty helpful in general. And it's because once you see someone draw a clock, you can look and see if their clock drawing gets better or worse with treatment. If she doesn't like drawing a clock, you can ask the doctor if he'll have her draw another figure like a cube, which also would help. But those visual constructive tasks, as I mentioned, are so sensitive tests for Lewy body disease that they are extremely helpful. I would tell you that we all are working on tests that are easy and simple to use that the average physician can do right in their office that help them make the diagnosis. Willow, is there anything that can be given for sleep without negative side effects? My grandfather wakes early and stays up all night. He had negative side effects with some other medications. Well, no medicines have side effects. There's no medicine without a side effect. Even aspirin and Tylenol have side effects. So you should always discuss these things with your doctor. If sleep is a real problem, you can check and see if there's a sleep specialist in your area because they can go through what's called sleep hygiene, and there are a number of non-pharmacological approaches, that's non-medication approaches, that can be quite effective. So, for example, looking at how someone's eating and what their activities are. For example, bed should only be used for two things, intimate relationships and sleep. So watching TV in bed tends to lead to bad sleep habits later on in life, and so, for example, moving those activities out of the bed sometimes can improve sleep patterns. There are some non-pharmacological approaches like lavender oil or chamomile tea that can be effective in some people. So talking with a sleep specialist, if your doctor doesn't know the answer, may be very helpful. And many hospitals have sleep labs, so they should be able to help you.
For about 2 or 3 more questions. We're down to the last 2 or 3 minutes.
Okay. Let's see. Any preventatives? Great. Dale asks. No, there are no things that actually prevent disease. We tend to think that eating healthy, a Mediterranean-style diet, lots of fresh foods, very low in saturated fats, exercising on a daily basis for about 20 minutes a day, staying mentally active and socially engaged as a group may provide some preventive benefits, reducing the risk of developing dementia, but it's not absolute. But those things that are good for your heart are also good for your brain, and so I highly recommend those type of activities. I think I'll take one more question. Let's see. Aaron says, after a Lewy body diagnosis in 2010 and being put on meds, I'm not sure what the major meds are, my mom now is in a remission. How long can we expect her to continue doing so well? Again, I give specifics, and you should talk with your doctor about this, but remissions can have very robust responses to medicine. That's why I think it's so critical to think about each individual symptom and how you might treat those symptoms. By addressing each of those individual symptoms with the correct medication, you can have someone really, really sort of halt that progression that you're seeing in terms of their symptoms. But remember, the underlying disease is still continuing. We have nothing to treat that. But people can have a very long period of time of a great response to medication, but it's impossible to predict on an individual basis how long that period will last, but enjoy that period for as long as you can and enjoy it with your mom and do all the things that she likes to do. I think that pretty much ends our time. I want to thank you all for the great questions. I think we had over 260 people online at the height of the presentation. I hope you found this informative. I think we're going to archive it. Is that correct, Angela?
It will be on our website in the next day or so, and we will send an email out to our attendees and our newsletter subscribers, letting them know exactly how to access it online.
Okay. Thank you all for your attention. I want to thank you for your great questions. I'm sorry I couldn't get to all of them. There were just way too many to do, but I think I tried to cover the ones that sort of covered the the major topics. Thank you for your attention. Have a good day.
Thank you, Galvin, and ladies and gentlemen, thank you for your participation. Please look for our email and share the link with a webinar with friends and family who may want to know more. For October is LBD Awareness Month. To get involved, visit www.lbda.org and click the graphic for our Awareness Month campaign and join today and get listed in our Hubs of Hope directory, and I'll help you connect with other families in your region. Thanks so much. Bye-bye.